So this is the first of a three-part series on gendered health in aging. In general, these things are going to be applicable to, many women and men, but we're focusing predominantly on adult and geriatric issues here. The first segment will be on women's health, and then we'll do one on prostate health, and then we'll do one on general men's health. So I do need you to remember that gender is something somewhat different than sex. Sex, to a sociologist, is being male or female, your biologic sex. Gender, on the other hand, is the lived identity that one has. Now, for the majority of us, that's going to match, but that's not always a given. And even in those people who the gender matches, the gender will actually vary somewhat from society to society. So the role of a female in a primitive society or a more advanced society is going to potentially be very different. So sex is something that is biologically defined, is going to be pretty consistent throughout everyone with that sex. Gender, on the other hand, is a very different thing. So most of the things that we're going to talk about are gender. Aging is definitely a gendered phenomenon here in the United States. Women have different opportunities than men, different availabilities of health care, etc. The other thing to remember, of course, is that more women are poor than men, so that is something that you'll have to keep in mind. Statistically, women use more services than men. However, once you reach geriatrics, that difference is actually not very large at all. Predominantly, the differences are related to childbearing issues and the fact that women are the kin keepers and are very busy keeping their children at the provider, and often as part of that will make appointments for themselves. When we talk about feminism, I think it's really important to remember that feminism is not, one monolithic concept. There is, I think, two major elements of feminism that you want to think about. One is equity feminism, that just basically says that men and women should be treated equally. On the other hand, gender feminism says that women, in fact, have unique needs, and treating them the same is not logical, that they need to be treated in a way that addresses their both biological and social roles. So just to keep that in mind. So another thing sociologically to remember is that based on some research that I did a while ago but haven't published, I did find evidence in long-term care facilities that elder abuse in a high percentage of patients is actually just intimate partner violence grown old. So a lot of those folks that are being abused by their spouse. There definitely is an element of children or others abusing the elderly, but in fact the majority of elderly people that have violence perpetrated against them have it by their partner. So that's just something to keep in mind. The other thing sociologically is that as the baby boomers age and as we live longer, there's going to be more of a need both for folks that are sensitive to elder needs as well as the specific care that needs to be carried out. So some specific syndromes of aging related to women. Postmenopausal bleeding is any bleeding that occurs after the woman has been without a period for a year. So by definition, if a woman is without her period for a year, she's in menopause. Any bleeding that occurs after that raises concern of cancer. And so the biggest worry is that maybe as many as 10% or maybe even as high as 25% of the women that have postmenopausal bleeding may have an endometrial cancer. Other estimates are even lower than that, but at any rate, it is something that is concerning and something that you need to be ruling out. So other causes that can occur that cause postmenopausal bleeding would be just some mechanical irritation related to vaginal atrophy, polyps that occur either on the cervix or in the uterus, endometrial hyperplasia, and there can be some hormonal effects, although, again, that would not be particularly common. Uterine fibroids are a fairly common phenomenon, but they are not a very common cause of bleeding. So as many as 10%, maybe even up to as many as 40% of premenopausal women have uterine fibroids, but they're not usually a cause of bleeding. So whenever a woman has postmenopausal bleeding, obviously you could do a good symptom analysis to try to figure out exactly what's going on. On the other hand, in general, you're going to have to do physical exam, probably, including at least a pelvic and maybe a rectal. If you see an obvious cause of bleeding in the vagina, whatever, a large laceration, that may be enough to explain the bleeding. On the other hand, if you don't see an obvious cause, the majority of women are going to have an endometrial biopsy. It's fairly low cost, it's pretty sensitive, doesn't pick up things like polyps, but it picks up most of the concerning causes of postmenopausal bleeding. An alternative, if you've got a woman that really does not want to have an endometrial biopsy, it would be difficult to obtain. Many primary care providers do endometrial biopsies themselves, but many do not. So sometimes that means a referral out. You might be able to get a transvag ultrasound a lot more quickly. If you do that, which is a second choice, you need to be aware that if it's negative, you can probably consider that workup adequate. However, if the endometrial stripe is thicker than 4 millimeters, if the endometrium shows any heterogeneity, if they can't see the endometrium, or if the woman has persistent bleeding, she's going to need a endometrial biopsy. So also, if the woman has been on, estrogens, especially if they're unopposed, in general, they're going to get an endometrial biopsy. And if that's not conclusive, they'll get a hysteroscopy. At that point, they'll often be with specialty care. Menopausal symptoms, very common. Menopause, by definition, the average age is about 51. There is a fair amount of variety, though. Some women have menopause in their 40s. Some women are in their early 60s by the time they go through menopause. So again, menopause by definition is lack of a period for over a year. So when a woman is menopausal, in the old days we used to do an FSH to prove she was menopausal. Now, if she is without a period for over a year, we just assume her to be menopausal. You don't need to do an FSH. If, on the other hand, especially if it's an off-time menopausal situation where the woman has amenorrhea for over a year, but you wouldn't necessarily expect her to, you definitely would want to think about other testing. Pregnancy, of course, might be a consideration, although if it's over a year, that's not going to be particularly probable. But thyroid and a general panel of labs is probably going to be indicated. 75% of women get hot flashes, also known as hot flushes or power surges. And even when they reach their 70s, about 10% or so are still having them. So very common phenomenon, more common in African American women, less common in Asian women. Seem to be more prevalent in women of low income, women who smoke, and women with a higher BMI. So what is a hot flash? Well, basically it's a 2 to 4 minute sensation of Flushing, heat up in the face, upper chest, sweating, palpitations, anxiety. Some women get a few, some get many a day. Some get them at night, and it interferes with their sleep and interferes with their relationship sometimes, because sometimes they have to sleep with the window open, which is not always all that popular with their partner. Why do women get hot flashes? We think it's probably just the normal process of estrogen withdrawal. Probably a surge of GnRH, but I'm not sure that we completely understand them. So sleep disturbances, obviously if you've got hot flashes, you're going to be more likely to have them. You can lower the room temperature. Sleep deprivation is likely to impact your mood. It will override your REM sleep and again interfere with your restfulness of sleep. Some folks use Lunesta. It actually works on the benzodiazepine complex, but it's not particularly controlled, at least as of right now. Melatonin might be some help, but the evidence does not seem to be particularly supportive of it. So if you've got somebody who has moderate to severe hot flashes, short-term estrogen is about 80% effective. So you can use just the regular equine or Premarin. Premarin's called Premarin because it was from pregnant mare urine. So basically they take the urine from pregnant horses and they isolate the estrogen from it and put it in a pill. There's others that are actually synthetically made now. Those are usually noted as such. They can be used transdermally. There's a number of different ways that estrogen can be given. So if you do put somebody on estrogen for hot flashes, make sure that you do taper them off or the hot flashes are likely to come back. So bioidentical hormones are quite interesting. There's a great interest in them. Some people feel that natural is better, but remind ourselves that anything made from plants, animals, or minerals is natural, including things that are obviously not very good for you. You can use a topical estrogen like estrase. The estring is a insert intravaginally that secretes the estrogen. And a woman who gets a prescription for an FDA approved hormone gets all sorts of information from the FDA regarding risks, the kind of things that you hear on television as far as potential side effects. Compounded medications do not have that requirement, and so patients will assume that they don't have those risks, even though the evidence seems to be that they probably have roughly the same concerns. Different people have different values around this. Sometimes it's actually really helpful for people not to get the information, printed information, just because it causes more anxiety. So be aware of what your resources are. I have a compounding pharmacy across the street from me, so that does give me some definite options, but that is something to think about. When you compound estrogens, they can actually vary the amount of E1, E2, and E3. All of these hormones are slightly different. They have different effects. The gynecologists that I work with will often alter the level of each one. I'm not sophisticated enough to know exactly how to do this, but some of you that do work with patients may develop the ability to make it more specific. Other non-hormonal treatments for hot flashes include SSRIs, SNRIs, as noted, Cymbalta does seem to definitely work in some people. Some of the SSRIs don't have any evidence, but others seem to have sort of mixed evidence. So it's really one of those things that's kind of trial and error. Some patients seem to get relief. Gabapentin's about 60% effective at 900 milligrams a day, so 300 milligrams 3 times a day. 60% effective, so that's definitely better than placebo, which is about 30%. So other treatments, you can use progestins, you could use clonidine. Obviously those are second or third line. The North American Menopause Society recommends trying the non-prescription or alternative therapies, although they really don't seem to be substantially better than placebo. Placebo, on the other hand, gets 30% effectiveness. So if you use exercise or the phytoestrogens or the black cohosh or evening primrose, you're probably going to get at least 30% effectiveness with few, if any, side effects. Definitely something that is worth exploring. Vaginal atrophy, many of us still call it atrophic vaginitis, but the feeling is it's not really an inflammation per se. It's more of an atrophy. It's related to low estrogen state. The clinical findings on pelvic exam are mucosa that is pale, dry, smooth, shiny, thinned epithelium, less rugae. pH will increase. And there will be a little bit of narrowing of the vaginal vault, and there might even be some telangiectasias. The maturation index doesn't seem to be very helpful. Estrogen levels, probably not helpful. Endometrial stripe, probably not helpful. So again, unless there's a reason to do any of these otherwise, most people are just going to go ahead and treat this topically and or with oral estrogen supplementation if the basic lubricant type medications don't work. Obviously, if there's physiologic change of the vaginal mucosa, sexual dysfunction is a not unexpected result of that. So when you have somebody with vaginal atrophy, obviously rule out, STIs, BV, dermatitis, lichen planus, any of those kinds of things. Once you've ruled those out, you try Replens on a schedule every couple of 3 days, not just when they're going to have intercourse, and then add another water or silicone-based lubricant at intercourse. They do suggest increased sexual activity that'll increase blood flow and hormone changes. Estrogen is definitely the most effective treatment for vaginal atrophy, but of course you do need to consider the contraindications of estrogen, as well as some women are not very excited about going on estrogen. Local treatment, the lower the dose, the better. So you can use the ring, you can use Vagifem, you can use creams, any one of a number of different prescription options is available. So if you have somebody that you're doing systemic therapy with, they really should not have unopposed estrogen. So you do need to add a progestin, either continuously with them or cycling. Most women would prefer it continuously because they don't like the idea of having periods. Obviously, if a woman has a history of breast cancer, in general, estrogens are going to be contraindicated, although a non-estrogen tumor, it might be an option, but in general, you're not going to use these medicines in any woman that has a history of breast cancer. Other menopausal symptoms include mood disorders, decreased collagen, skin and bones, so they can get joint pain, skin dryness. Menstrual migraines may increase or decrease related to menopause. A lot of women see that their menstrual migraines just go away as soon as they've had menopause, which is a welcome relief for them. Some other women actually do have an increase in their headaches related to menopause. Balance issues seem to be a bit more common in menopausal women, especially if they have a little osteoporosis or osteopenia associated with this. Then the injuries associated with Fuchs injuries are going to be substantially more. One would assume you're familiar with a Colles fracture, but that is definitely something you should be aware of. It's not usually a hard fracture to diagnose. They usually have a substantial deformity, and it's usually an emergency room type thing. The other issues of menopause, as we noted, there'll be some bone loss. We think there's probably some cardiovascular risk factors, although there's varying data regarding that. So estrogen treatments, again, transdermal's preferred. There's a whole bunch of different options. There's plant-based, there's bioequivalent. They are preferred by many. There's no proof per se that they are safer, but patients often believe that they are. In general, the lower the dose, the better. Remember that alcohol can potentiate oral estrogen, but there's not really a whole lot of studies about that, but just, make sure that someone's not drinking excessively. Progestin therapies, if you've got somebody who has unopposed estrogen, you can actually develop endometrial cancer in as little as 6 months if it's unopposed. So you just need to keep that in mind. Urinary incontinence. So urinary incontinence is one of those things that we probably undertreat. A lot of folks will be like, oh, I'm older, it's just something that happens. So less than half the women that have incontinence ever get any help from their providers. In general, they suggest that we be a lot more aggressive trying to screen for incontinence, just because women, as noted, will feel like it's a normal change of aging. A lot of women start using pads, and there are things that we can do. Especially if someone has something like diabetes, then you definitely want to ask. So what are the types of urinary incontinence? Well, a lot of people assume that stress incontinence is the most common type. Women have babies, their structural musculature around the sphincters decreases, and the ability to close the sphincter decreases, and they cough and they pee themselves. Well, interestingly, stress incontinence is not really that much more common in women that have babies than women that don't have babies. It seems to be more related to weight. So if you look at nuns that are overweight, if they cough, they often will lose their urine, just like women that have had a lot of babies. And unfortunately, having a lot of babies, it's a little harder to get that baby weight off sometimes. And on average, women that haven't had babies are a bit thinner than women that have. The other type of incontinence that is pretty common is urge incontinence. And this is obviously hit the airwaves with lots of ads about the gotta go medicines, gotta go. And basically this is an irritation of the detrusor muscle, which is the bladder muscle. And basically it's just spasming, and so those women either have to go to the bathroom or will actually lose their urine. The quickest and easiest thing to fix that can cause urge incontinence is a urinary tract infection. So if a woman complains of urge incontinence, the first thing you have to do is rule out a UTI. Doesn't all that commonly turn out to be that, but if it does and you fix it, you have a very thankful patient. And so another thing that can cause it is so-called interstitial cystitis, which is a kind of chronic inflammation that sometimes requires urology intervention and medications that can be applied topically within the bladder. Mixed incontinence is probably the most common type. So you have a woman that has a combination of stress and urge. I say a woman just because the majority of people having urinary incontinence are women, but not all. Overflow is actually more common in men, and usually that's a man that has a enlarged prostate gland and is not completely emptying his bladder, and therefore sometimes will have problems with dribbling, a weak stream, and incontinence. So. Also, of course, when you're thinking about detrusor issues, make sure you think about disc issues, B12 deficiency, Parkinson's disease, and other similar rule-outs. So, just make sure you get a good history and possibly some laboratory testing and a careful physical exam. So once you have somebody with urinary incontinence, the physical exam, again, the above-the-waist physical exam is going to be looking for things like Parkinson's disease, orthopedic issues that can cause what they call mobility-type incontinence. So if you've got somebody that really can't get to the bathroom, then they're not really exactly incontinent, they just can't get to the bathroom quick enough based on their mobility. The genital exam in women, obviously you look for vaginal atrophy, you look for narrowing of the introitus, you look for inflammation, and you're looking obviously for masses and tenderness. The yield for that is going to be pretty low, but in general that's still considered part of the evaluation. History, which of course should have been done before the physical exam. If you've got a sort of sudden onset, you're a lot more suspicious of an infection or possibly even a neoplasm. Therefore, if you have that sudden onset and there is an infection, you could consider referring them to urology for a cystoscopy. Looking at the symptoms and precipitating factors, sexual and bowel functioning, what medications are they on. Some actually unintentionally make incontinence better, and then when you take patients off them, they'll have problems with incontinence again. An example of that would be Sudafed. So Sudafed increases the sphincter tone, and sometimes people are on it and then go off it, and their incontinence gets worse. Symptom diary is a really useful thing. Find out what times of the day they're having it, how bad it is, all of those kinds of things. So obviously a minimum laboratory test is a urinalysis. For blood testing, obviously you want to get a glucose and probably a serum calcium, so a CMP will give you both of these. Bladder stress testing can be done by specialists to actually do what they call urodynamics. A simple way of doing that sometimes is to do a provocation test where you have somebody that you're doing a pelvic exam on and you basically have them bear down and cough and see if they leak a little bit of urine at the time. Check a post-void residual if there's any concern about post-voiding having some left over. This is definitely important in men, but also important in women, just because when they have sort of changes related to the uterus moving down and prolapsing just slightly, they can actually cause pocketing of urine in the bladder, and they do have problems with emptying completely. Some of those women can actually change position when they're on the toilet, empty better. So if you've got a high post-void residual, then obviously there's a slightly different situation there. Now, who needs to go to a specialist? Obviously, if you've got somebody with, abdominal pain or hematuria without any evidence of a urinary tract infection, you think they've got a fistula, if they've got any sort of neurologic issues that are causing their incontinence, then obviously you get them to neurology. If they've got evidence of a mass, so basically it's just sort of common sense who you need to get to a specialist immediately. Now, elective referral is a little bit more complicated, just because, as we know, the challenge is that the majority of women with urinary incontinence do not have substantial benefit from surgical repairs. There's a percentage of women that definitely do get better, but unfortunately the number of women that fail with surgical repairs is at least 50%. A lot of women assume, and a lot of providers assume, oh, they've got incontinence, I need to refer them to GYN. They'll do a hysterectomy and do a anterior and posterior repair, fix everything, put it all back in the anatomic alignment, and their incontinence will go away. Unfortunately, that is nowhere near as effective as most people assume that it is. There are times where that is where you end up. But for a lot of other patients, medical and behavioral approaches are going to be just as effective, if not more so. So just keep that in mind. So obviously, you're going to have to try to decide who can we treat and who do we have to refer. So obviously, depending on the type of diagnosis, is it urge incontinence? Is it stress incontinence? What can we do? Weight loss is almost always helpful, although, as we know, is quite a challenge for everyone. Pelvic muscle exercises, so-called Kegel exercise. You're going to do multiple sets, and unfortunately, the effect of Kegel exercises tend to disappear once you stop doing them. So Dr. Kegel does deserve a thanks, although unfortunately a lot of people overestimate the benefit of Kegel exercises. It is something that, as noted, if you can continue and keep them up, they can be really helpful, but not always. So sort of the final slide here is in relation to medication treatment for urinary incontinence. If you have somebody that has urge incontinence, the antimuscarinics can be helpful. Some of these have more anticholinergic type effects than others. SNRI does have some benefit, although it is limited usually by side effects. The usual 60 milligrams a day does not seem to be enough to usually get effect, and so 80 milligrams a day is usually necessary for urinary incontinence, and also has a very modest benefit. Estrogen, as noted, if you have a uterus, you generally want to oppose that with progesterone, and then procedures also can be done. A medication that's not listed on here is the new beta-3 agonist, Myrbetriq, which does seem to have some benefit as far as overactive bladder without having the anticholinergic side effects. So that is another option, although unfortunately for a lot of patients it continues to be fairly expensive. So I think the take-home here is to remember that you need to do a differential diagnosis with urinary incontinence, and then depending on the type of incontinence, success rates are going to vary. Neil Resnick, who was a geriatrician from Harvard a number of years ago, at a talk that I went to, suggested that at least 1/3 of the people that come in with urinary incontinence can be absolutely cured. 1/3, you can probably make them at least some better, and unfortunately 1/3 you're going to have to manage them with pads and other issues. So be realistic about the probability of success, but also don't just assume that no one's going to get better and treat everybody with pads and symptomatology. So this concludes the women's health geriatrics talk. The men's health talks will follow. And of course, obviously, there's a lot more to women's health than what we covered here, but it at least touched on a few areas that are more specific to geriatrics and gerontology.